Hello everyone, welcome back to my channel. And this is a video series of basic concepts of medicine. And today we are discussing about pneumonia. So before we dive in, let's just break down concepts and have a clear picture of what pneumonia is and how do we differentiate between pneumonia and other common terms like pneumonitis and lower respiratory tract infection. Pneumonia is an infection and inflammation of the alveoli and lung parenchyma. The etiology here is an infective etiology. There's a bug or a pathogen which causes infective symptoms in the alveoli, and that leads to symptoms and pathophysiology. The other term is pneumonitis. So, pneumonitis is inflammation of the alveoli and lung parenchyma. There's no pathogen involved, there's no infective etiology involved here. It is only inflammation, and this could be secondary to irritation of the alveoli, secondary to, say, hypersensitivity reaction, secondary to inhalation of any irritant, and secondary to chemicals or drugs. The other is LRTI, which is lower respiratory tract infection. So this is again an infective etiology. The word itself has lower respiratory tract infection. So infection is pertinent to the bronchial tree, the bronchi and bronchioles, but does not involve the alveoli or lung parenchyma. So how do you differentiate between pneumonia and LRTI? Because the etiology is similar, which is the infective etiology. In pneumonia, we have, in addition to lower respiratory tract infective symptoms, such as in LRTI, we have symptoms of cough, sore throat, productive cough or dry cough, and to some extent, some shortness of breath. In pneumonia, you have all of the symptoms of lower respiratory tract infections. In addition to that, you have systemic features like lethargy, fever, and sweating episodes or productive cough, and your blood picture shows raise in infective markers, which is CRP, WBC count. Most importantly, on a chest X-ray, if you take a chest X-ray of a patient in lower respiratory tract infection, you do not see any consolidation. At the max, you can see some endobronchial thickening on the chest X-ray, but in case of pneumonia, you see consolidation because the alveoli and lung parenchyma is involved. So that's a definitive diagnosis there. Going back to pneumonia, let's continue our discussion. So what are the organisms that cause pneumonia? The most common are bacterial. For example, Streptococcus pneumonia, Staphylococcus aureus, anaerobic bacteria, and gram-negative bacteria, for example, Klebsiella. The other is atypical bacteria, which are Mycoplasma and Legionella. Also some Chlamydophilia, which is not very common. So what makes this atypical organisms atypical compared to the normal bacterial organisms? So atypical means they do not have the cell wall, and that makes them atypical because they don't appear as the regular bacteria. The absence of cell wall, the antibiotics which we give differ because we cannot give the regular penicillin group or cephalosporin group because all of these are beta-lactams, and beta-lactams act by damaging the cell wall, which these organisms don't have in the first place. So you need to come up with another antibiotic, and there are specific antibiotics which are for atypical cover, we say, that is clarithromycin and doxycycline. Common viruses causing pneumonia are influenza, influenza A and influenza B, SARS virus, and adenovirus or RS and RSV virus. Fungal organisms causing pneumonia, we have PCP, which is Pneumocystis carinii or Pneumocystis jirovecii. Then is histoplasmosis and aspergillosis, and these are the fungal organisms. Based on the setting of where a person develops pneumonia, it is classified as CAP, HAP, VAP, and aspiration pneumonia. Coming to CAP, which is community acquired pneumonia, this means that the bug which the patient is having pneumonia due to is caused by a bug in the community. These are susceptible bugs because they're not exposed to the antibiotics. It's easy to treat. Potentially, it's easy to treat. And we can start them with antibiotics, basic antibiotics like penicillin group of antibiotics, usually comoxiclav or amoxicillin. and that should be taken care of. The most common organisms are again Streptococcus pneumonia or Staph aureus. A patient who comes in with suspected community-acquired pneumonia, you would do curb scoring, curb 65 score, we say, and that would differentiate whether this patient has mild, moderate, or severe pneumonia. And it is important to differentiate this because based on this, you can either admit the patient or treat them back in the community by giving them oral antibiotics. 65 has the components are C for confusion, which could mean that there is low blood supply to the brain, and this could be because of potential hypoxia or hypotension. Then U is for urea. So urea is not directly related to pneumonia as such, but having raised urea on a setting of pneumonia means that there is multi-organ failure, that is the kidney is involved here, which indirectly means that the infection is severe or moderate. And it also means that the body is trying to compensate fighting this organism, and it is losing the battle because in case of severe infection, there is first response, there is cytokine storm, and there is vasodilatation. But in case of kidneys, there is renin-angiotensin system, which causes vasoconstriction at the afferent arterioles, afferent renal artery, and this causes pre-renal AKI, or it also could have renal AKI because of the ATN, which is acute tubular necrosis. And R stands for respiratory rate, where respiratory rate is more than or equal to 30 respirations per minute. Then B stands for blood pressure, where blood pressure is less than systolic 90 or diastolic 60, so 90 over 60. All of this scoring is useful for classification. What's interesting to note is that among the score, this is a very widely used score, especially in the accident and emergency A&E departments and also in acute assessment units, time of admission of the patients. But it's interesting to know that it does not take into account saturations or blood gases, PaO2 of the blood in the blood gas. There are other scorings like PSI, pneumonia severity index, which takes into account the saturations. And there's another one, SMART COP, which again takes into account the saturations and PO. To remember here is that irrespective of your curb score, if the patient has saturations less than 92% and they have oxygen requirement, you would invariably admit the patient. Imagine you have a patient who is presented with lower respiratory tract symptoms and systemic symptoms, and you have done a chest x-ray which showed consolidation. Then what else do you want to do for this patient? You officially know that this is pneumonia now. You check their saturations, and if it's less than 92%, you start them on oxygen. You check if they are dehydrated, if they need any fluids, and start them on fluids. Then you start giving them antibiotics because you know this is an infected cause, it's a pneumonia, and you want to treat them with antibiotics. You would start them on comoxiclav, which is first line for pneumonia, bacterial pneumonia. And then if you think about that they might have exposure to atypical organism, which we've discussed, then you might start them on clarithromycin as well. Then you would do an ABG once they have oxygen requirement to check what's the PaO2 in the ABG. At the same time, you also want to know the pH and PCO2. So this will guide us, or it will initially give us an idea of what their ABG looks like, so that in case they further deteriorate down the lane, you have an ABG to compare and whether this is an acute decompensation or it's just a chronic form. So you want this to be as your benchmark. You would also want to do some sputum culture and blood culture for the sake of completion, and complications which you can expect with pneumonia. In general, the mortality rate of pneumonia is low if it is a community-acquired pneumonia and if it is treated in the community. So the mortality is less than 1%. But in case there is hospital admission for pneumonia and especially ICU admission, then the mortality increases to about 50%. Complications of pneumonia are: one is an abscess formation because the localized infection is worsening and this has just formed into an abscess. You can also expect a pleural effusion along with the pneumonia at the site of consolidation. The other is it could form something called necrotizing pneumonia, and this especially is important to note with Staphylococcus aureus because it is notorious to have a a toxin called PVL toxin, which can potentiate to form this necrotizing pneumonia.